This session is on necrotizing fasciitis, and we are very fortunate to have Ms. Lorraine Harry with us, who is a consultant plastic surgeon based at the Morriston Hospital in Swansea, and who also provides orthoplastic input at the Major Trauma Centre in Cardiff. Lorraine is also the lead for plastic surgery across the South Wales Trauma Network. Now, for this session, I'll start off by presenting a case of my own, and then Laws will take us through her experience of dealing with this orthopedic emergency. So this 66-year-old gentleman who was extremely fit and active, whose day-to-day activities involved sea swimming, cycling, and walking, went for a walk with his dogs a couple of years ago and was probably bitten by a spider. About a couple of hours after this suspected spider bite, he developed excruciating pain in his leg, and his daughter brought him to the hospital with a painful, red, hot, swollen knee. Interestingly, he was afebrile at that stage. However, his vitals showed that he had tachycardia and hypotension. He had cellulitis on his leg, extending from the middle of the thigh to the distal leg. There was no swelling within his knee, and he had completely pain-free range of motion from 0 to 90 degrees. The interesting finding at that stage was that he had patchy bruising on his posterior thigh. His initial bloods revealed a CRP of 209 and a white cell of 22.4. The initial diagnosis, or the suspected differential diagnosis at that stage, was septic arthritis or cellulitis. Now, given that his knee had pain-free range of motion and there was no effusion, we excluded septic arthritis of the knee clinically. I did suspect necrotizing fasciitis at that stage. However, as I'd never seen a case before, wasn't entirely sure. Got a second opinion, and they weren't sure either. We decided to treat this as cellulitis, but continued with hourly observations because we did suspect necrotizing fasciitis. 24 hours later, he did respond to the initial antibiotics. His heart had slowed down a bit. His blood pressure had improved. However, his cellulitis had spread proximally, and he now developed blisters on the back of his thigh. So I got a third opinion at that stage. However, it wasn't very helpful. We carried on observing the patient, and just a further 6 hours later, he became increasingly confused, and the blisters started spreading distally. The CRP had jumped up massively in spite of the treatment he was receiving. We made a diagnosis of necrotizing fasciitis and took him straight to theatre. Over to you, Laws, now for further management.
Well, thank you, thank you, Raoul, and thank you for the invitation to present in the Sunrise session. So we're talking necrotizing fasciitis, and that's exactly it. You know, not many of us have seen it in terms of the clinical exposure. It is very rare, but of course, cellulitis is actually common. So there's a very difficult diagnosis, and we're talking about the fulminant progressive bacterial infection that gets within the fascia, and it then spreads, and then it causes destruction to the tissues. It's been sensationalized in the media. We talk about a flesh-eating bug. And also, I mean, if I can thank Dean Boyce for a few of these slides. I don't think that he reads the Sun, mind, but I think that he was able to get a few of the media pictures. But so we know that actually the concern is valid because these are the infections that we're talking about. This is the mortality rate. We very rarely come across some condition that is so devastating. There are different types. They're mentioned here. Type 1 is the polymicrobial. Type 2, the group A strep. Types 3 and 4, marine and fungal, are very, very rare. Why are these infections so deadly? Well, we've discussed it's the delayed diagnosis. It's rare. Cellulitis is not. We infrequently get exposed to it. I think there are 500 cases reported incidents in the UK. So it presents very insidiously to many specialties, and there's a dilution then of when you get it. If you make a diagnosis as well, it's a really brave one, because as we've heard, actually you can have to do brutal surgery to these patients to treat them and then get them better. Here we have a real-time live microscopy of the fulminant organism. So this is what we're battling against. So really what I want to do is discuss how we can become more confident in diagnosing necrotizing fasciitis, and a little bit of the surgical overview as to how and what to debride. So, I mean, it presents in phases. You will have an early, an intermediate, and a late. And I'll give some pictorial pictures again, thanks to Dean Boyce, my clinical director, for giving me these. You know, the initial early phase, it doesn't really look much, does it? It's a bit of redness, a bit of tenderness, but you can see that it is progressing, and very helpfully and correctly, this is being marked and timed, and that's the key. In an intermediate phase, you begin to get bully, you begin to get skin fluctuation and induration. I think we'll all agree by at this stage, with the hemorrhagic bully, the necrotic skin, the crepitus, I think we'd all be confident in diagnosing this as a necrotizing fasciitis. The systemic signs, I mean, I used to be petrified as a plastic surgery registrar being called to see a neck fash, because I hadn't seen any when I obviously first started, and it wasn't very well presented. And I used to get called to the wards, and I remember someone actually sitting in a bed applying her lipstick with a red foot, and my consultant telling me that no, that's not necrotizing fasciitis. But you can be, it disarmed, because early in the stages, the skin looks normal, and the patient can be just a little bit off. But look for the pyrexia, the tachycardia, the tachypnea. And of course, once you get to your sort of anuria, your confusion, you know that this is a moribund patient that needs to go, needs to have something done. So what do? The differential should be high in your index of suspicion, and you do not delay with fluid resuscitation. You get the fluids in, and then you get the antibiotics in. And then you order the investigations at the same time. The fluid resuscitation is key, and you're needing to speak to your microbiologist, you're needing to speak to your critical care team immediately. Really, the only investigation that is diagnostic is the finger sweep test. Your surgical incision, your finger in, and you sweep it through. And if the fascia is involved, it'll just literally fall away. And then you send your samples for microbiology and histopathology. And then obviously, actually, you will begin to get your diagnosis. Radiology, actually, it shouldn't delay you going to theatres. I mean, there are radiological investigations. MRI does show up on T2 waiting, but this should not delay your surgery. Diagnosis and treatment is surgical. What about transfer to the plastic surgery unit? Well, if I'm next door in a room at either Cardiff or Swansea, I do want to know about this. But if I'm down the road 50 miles away, then no. And that's the key, really. All surgeons should be able to diagnose and treat the initial stage of it, because that's what saves patients' lives. What do? Well, you take your samples. We'll go through a scoring system in a minute. You give your antibiotics, your beta-lactam, your clindamycin, always with microbiology advice. And then you resuscitate. You're resuscitating at the same time, as I've mentioned before. Is there a role for hyperbaric oxygen? Well, actually, I've never had to use it. I've never been involved in cases on fellowship in Toronto or in the UK. But I mean, that's something to do with obviously oxygenation tissues and stopping the toxin that's being produced by the bacteria. So there is a role. I just don't have experience, but really you take to theatre, you diagnostically explore, and then you surgically debride. Surgical debridement, well, you're confirming the diagnosis. You are isolating the causative organism, and then you're defining the extent of that fasciitis and removing it. And we talk about the dishwater fluid. You never forget it when you get it, because actually it is putrid, it smells horrible, it looks horrible, and it really is classic. And once you have that, you know that you are needing, it's a race against the clock, basically. First debridement should be your last, because in essence, if you've not removed it all, your patient is not going to survive. And you need to reach healthy tissue with a safe firebrick. So we talk about zones of tissue. Zone 1 is the classic necrosis. Your zone 2 is then your early necrotizing fasciitis. And as you are cutting, you really do see that change in sick tissue. And then your zone 3 is your normal tissue, where the skin and fascia looks normal, and you actually need to take a 2 to 3 centimeter fire break of that normal tissue, and you're sending samples off. Urgent microscopy, urgent culture. You need to get those clear. It's like a cancer excision. Remember, it goes up and it also goes down. So muscle invasion is also seen in later stages, and this has an amputation rate. You just have to cut out what tissue is involved. The post-excision, well, we dress with betadine soap pores, simple dressing, and then the patient is supported and then returned to theatre 12 to 24 hours to then look and to assess the wound, and then we utilise back dressings until reconstruction. And that, usually then is when you do call your friendly plastic surgeon 50 miles down the road. It's usually after a second or third look. And there are various ways of reconstruction. In the main, we use split skin grafting, again, thanks to Dean for these pictures. But we can also require free tissue transfer. So, again, the reconstruction can be complex, but the patient has had to be cured and ready for treatment. Here we see a picture of an initial and secondary debridement. Those Charney sutures are a thing of the past, but they're doing a job here. And then you see, a repeated trip to theatres where actually we now have a stable wound bed and we are putting skin grafts on. And this, I think, is the fourth trip to theatres for this gentleman who survived. You may know the Lronex Score, the laboratory risk indicator for necrotizing fasciitis. It has 6 factors. This is the literature. This is the paper. Effectively, the maximum score is 13. You're measuring your CRP, your white count, your hemoglobin, sodium, creatinine, and your oh gosh, I knew I would have, that's right, it's your glucose. You say you're 6 and you remember you're 6, it's in there. But it's interesting because, a score of 6 or above is suspicious of neck fasc. And all you need is a diabetic with a red foot, cellulitis, and a chronic renal impairment to actually to hit the 6. So it is quite blunt. It is to be used as an adjunct, but it is a very valid tool. And I think that the problem is, of course, we don't see many, but it does help. So just to be aware of that. And then there's other literature that I've posted up here. Again, reviews, many case reports, because of course people, are not seeing this in their local district general or indeed teaching hospitals. As I said, 500 cases in the UK incidence wise. Okay, so in summary, we've got neck fasc as a high mortality rate. Early recognition can be curative. The only real investigation is a surgical incision. You put your finger in, you sweep the fascia, you get your dishwater fluid, and you excise all skin and fascia in a zonal manner and including the fire break. And of course, that may mean muscle, that may mean taking off limbs, you're excising the tissue involved. And the first debridement needs to be your last. I think I've hand back over to Raoul.
Thank you for this absolutely fascinating presentation, Loz. That was simply superb. I would like to ask you a question about this finger sweep test that you mentioned. Number one, who should ideally be doing it? Can it be even a junior doctor, an SHO, or does it have to be somebody senior with experience? And secondly, is this test best done in theatres, or are we allowed to do it under local anaesthetic on the wards, or even maybe in A&E?
So really good question. So first of all, I think if there is a patient who is moribund and there's a high index of suspicion, you'll already have got senior members of team. So if you are actually a junior on the ward asked and you see a patient like this, you need to be phoning your senior, your senior surgical colleague. I have done it as a junior. In fact, I've actually aspirated the blisters, which is far less invasive, because really doing a cut down in a ward or an A&E is a significant thing, and it's quite a scary thing. So I've aspirated blisters, and that's a good way of actually sending off some tissue or some fluid to get an urgent microscopy and an urgent culture. So I wouldn't, it needs to be done expediently, and I think that's the key. So if you are literally someone who has got that sort of, late presentation of a type 2 or type 1 group A strep, you need to be getting that. To be fair, I've only done one outside of theatres. So I think in terms of getting the patient through, what you don't want, and what has happened many times, as we all know, is that the patient goes to the MRI scanner, or they've got different reviews of people who are like, not sure, it's neck fasc, we'll just treat it long. And as I said, your case, your patient is a classic example. You had a high index of suspicion, but you had no support to, or little recognition, because when we don't see them, we don't know. So I guess to answer your question, really, it's not necessary, you're cracking open your chest or your whatever in A&E, but you do need to be doing that fairly quickly and responsibly. So maybe aspirate the blisters, call your registrar or your consultant. Remember, these cases are really difficult from a point of view of the anaesthetist as well. So the senior guys should be getting involved fairly quickly.
Yeah, that's great. That's really helpful. I'm sure this finger sweep test will give a lot of my colleagues the confidence now to diagnose this really devastating condition quite early on. I think we can give our listeners and viewers a closure on my case now. So just for everybody's information, what happened was this patient went to theatre 8 times for surgical debridement, followed by 3 plastic surgical procedures, and I'm pleased to inform that he survived his ordeal and is back out sea swimming, cycling, and enjoying life. Thank you, everybody.
Thank you.
Thanks, Laws.
Thank you.